Hi, I'm David Bell. It's my pleasure this morning to welcome Courtney van Houtven from Duke, who's going to talk to us for about 35 to 40 minutes on the economics of informal care. Thank you.
Thanks so much. So I want to thank Jose Luis for inviting me, even though he saddled me with this very difficult title and hard thinking to get to put this paper together, or this project together, and also the organizers. It's great to be here again in London and at this conference. So the outline of my talk today is I'm going to go over the role of informal care in the US, talk about the current policies, all 8 of them that I could think of, that support caregivers, talk about the empirical evidence as it stands, what we know, what we may need to know in the future. What is an optimal policy to support informal care, and do we know enough to recommend one? I'm taking a very US focus. As all of the experts in this room know, the action is elsewhere, not in the US in terms of informal care support policies, and I've been enjoying listening to all of you tell me about what's going on in your countries. I'm going to stick with what I know and talk about the US. So just to give a preview of the results of this very technical talk, do we know enough to recommend one? Of course, the answer is no. As researchers, I'm being glib here, but as researchers, we need to know more in order to understand whether we move forward with policy change. But in terms of the economic research, I actually do think we know a lot. I think there are 2 key questions that will help us know what we need to know to really form policy change. But in addition to the economics research, there's a role for soul searching and political will. So I'll talk about both the economics research, which I'm more comfortable with, and some of the soul searching I think that we need to do in the US to move forward with any kind of informal care policy. So first, the role of informal care in the US. So just so we're all on the same page, the definition that I like to use is that an informal caregiver is a relative, partner, friend, or neighbor who has a significant personal relationship with and provides a broad range of assistance to an older person or adult with a chronic or disabling condition. So in the US, most frequently, we're in this column here, people are untrained. Less than half caregivers report that they've received the training that they deem necessary. They're providing unskilled tasks in general, ADL and IADL assistance. Generally, they're unpaid, providing non-intensive care. So by intensive, we usually use this 20 hours or more a week as an intensive caregiver. And they're co-residential if they're a spousal caregiver or partner, or they're in town if they're an adult child. Of course, there's tons of heterogeneity in the types of tasks and the roles that caregivers have in your countries and in the US as well. Some are actually paid in kind or through indirect transfers or payments. Siblings get together and pay the caregiver. So there's a lot of variability, of course, in what's going on in the quote-unquote informal market. Very precise estimate, how many are they? There are 20 to 65 million. That's a very tight estimate. I like to go with the more 20 to 30 million estimate, because if you go with this 60 million here, this is 30% of US adults would be providing informal care. I think that might be somewhat high, but it could be plausible. It's really hard to measure this, so I like to provide this full range. Numbers are going up. People don't know how much they're going up. Who are the caregivers? So this focuses on the definition that looks at family. Family, of course, is the most common source of informal care, but friends and other people do provide it, organizations informally. The majority of family members who provide care to people with multiple chronic physical and cognitive conditions were female, 58%. Age 50 or older, around 66%. Caring for a parent, 38%. So we know daughters are slightly more frequent providers and more intensive providers. Sons also play a role, and increasingly a larger role. The care episode is 3 to 4 years on average for almost half of them. About half caregivers are employed, and half make $50,000 or less annually. Well, that's very fine to know that they make $50,000 or less annually, but how do they compare to non-caregivers? This is very descriptive, but I took data from the Health and Retirement Survey and plotted out this Kahneman and Deaton's happiness threshold. So right above the $70,000, then your happiness doesn't increase too much, but the more you get below this $70,000 in household income, the less happy you become. So you think we might want to care about this threshold a little bit. This shows the blue and the green are the caregivers who provide care to their parents and the caregivers who provide care to their spouses. And these are three bars here are below this threshold, and they're all caregivers, and the non-caregivers tend to be above. It's highly descriptive. If we control for age differences, et cetera, we may see a different picture. I have played with it with age, and it seems to be that this holds descriptively, at least, no matter how you defined the parents being alive and a spouse being alive, parent being sick, spouse being sick. So there are some differences descriptively in income across caregivers and non-caregivers. I want to give you a brief idea about the payments for long-term care. This is a slide that may look familiar to one of my co-authors in the room. This shows the spending by public and private sources on long-term care. $230 billion was spent in 2012. That's about 1.5% of GDP in the US. Of course, the most common payer is Medicaid, around 33%. Medicaid covers care in the home through waivers primarily. Medicare also covers post-acute care primarily in terms of long-term care. Home health care is provided as well as institutional post-hospitalization care in a facility. But most of the home care that's provided by Medicare is highly skilled, and you have to be homebound, so there are some strict limits on who can qualify. Out-of-pocket is the next greatest category, so 21.5% of long-term care expenditures are spent by individuals. Private insurance makes up just under 8%. So, of course, most private insurance policies right now cover care in the home from a formal care provider and institutional care with term limits, et cetera. The rest is provided by public or other private sources. Who are the care recipients? So I want to point out that it may be different from your countries, and that is that 66 to 78% of the people who need care in their homes only receive informal care. So this is really the primary source of care, and very few people receive formal care or both formal and informal care. And that's even among the most severely in need. There's been a lot of buzz about the value of informal care out there, and an excellent study by Lynn Feinberg at AARP, and she kindly shared her slide with me, tries to place the value of informal care. If we replaced all the informal care in the country with home health aid worker rates, so you pay them directly, the value of this care would total around $450 billion. So thinking about that prior slide, this is 2009 data, so it's slightly lower than the $230 billion I showed before. But this dwarfs the amount spent on formal long-term care, and it's more than what we would spend on Medicaid. I'll talk later about whether replacement methods to value caregiving is an appropriate method. But this is a really large value if you just think about the replacement costs in terms of what we spend on Medicare, Medicaid, and formal long-term care. Let me talk about the current policies that support informal care in the US. So before I get into the policies, I want to point out there's been long-standing advocacy to support caregivers from professional societies first to the American Medical Association 20 years ago or more, said the physician should conduct periodic assessments of the caregiver as well as the patient and provide training to caregivers. The IOM came out with the same statement more recently. We should train the caregivers. We should provide better training for them to help support them. This is echoed in lobbying groups, and the AARP is one, the Caregiver Action Network is another. But the AARP states on its website and in its mission, support for family caregivers is a key component of a high-performing LTSS system. And I would say that we do not have this high level of support for informal caregivers. Research institutes more recently are getting into the game. So this is the PCORI Institute. This is the Patient-Centered Outcomes Research Institute. It's been established through America's healthcare reform. Tons of money is going to it, and they're funding lots of research. And their definition of patient-centered care includes the caregiver explicitly. So caregivers are sitting on their grant review panels as well as patients. And what they say on their mission statement is the voice of caregivers are essential to our mission of helping people make better informed healthcare decisions and improving healthcare delivery and outcomes. So there's a lot more buzz about caregiving in the US, but very little policy change, that I would say. I'm going to go over the direct, indirect, modest, oops, I didn't want to push that. There we go. The indirect, modest direct, and substantial direct policies, of which there are 8 that I could identify. So first, the indirect policies that may affect caregivers. So the Affordable Care Act, of course, is U.S. healthcare reform, has features that could affect informal caregivers. One feature, of course, is that the long-term care insurance provision, the Class Act, failed, which implicitly increases the demand for informal caregivers by not allowing new financing for long-term care risk. There are other initiatives in the ACA that really may affect caregiving. Increased care coordination is a focus, increased attention to transitions of care, increased focus on preventing hospitalizations. These can affect caregiving demand and the role of caregivers, but I would say at this point in unknown ways. I can think of arguments for needing more help by caregivers and less help. Another indirect policy, and these are happening at the state level, is this balancing or rebalancing dollars away from institutional care and into the home. And I think Tamara Konecka pointed out nicely in her health services research article in 2014, and that is that people aren't really talking about the implications of rebalancing into the home and what they have on caregivers. And it really is something that I think we need to pay attention to. Let me talk about some indirect labor policies that affect caregivers. We have unpaid leave in the US. The Family Medical Leave Act's been in existence for over 20 years. You're allowed to take 12 weeks of care if you qualify. 60% of American workers or US workers qualify. 50 million have taken this benefit since it was enacted. 31% of them take leave to care for a family member. I think it's interesting to point out that there have been reports on why people don't take the leave, and almost 80% of them say they didn't take it because they can't afford to take it. There is a move to having also paid work leave in 4 states across the country. You're allowed to take up to 6 weeks. This is funded through payroll taxes, and your payments are commensurate with your wage. And I couldn't get statistics on some of the newer states, but California, 1 million people have taken advantage of this paid work leave. So now I want to talk about modest direct policies at the state level. Despite the fact that there have been national tax credits proposed since the Clinton administration, there really are only a handful of states that have passed modest tax credits of the level of $500 to $1,000 off your annual tax bill if you're a full-time caregiver, if you meet strict income limits. So these are sort of it's hard to get and it's not very generous, but it exists in a handful of states. This is kind of interesting in that it affects more the formalizing the role of informal caregivers. In Rhode Island in 2013, there was a new law passed that required the care plan to explicitly assess the ability and needs of the caregiver if the plan involves a caregiver for the Medicaid patient. So that means that there is actual recognition within the care team that we need to think about what the caregiver can take on and what the caregiver's abilities are perhaps, and some standardization. Around 30% of states voluntarily assess the caregiver comprehensively. Again, this is just one state, but these are sort of the modest direct policies that I could identify that affect caregivers. What about national policies that are modest? There have been, as a part of the Older Americans Act, the National Family Caregiver Support Program has existed for about 14 years. In the early years, it was around $120 million a year. Most recently, it's $162 million a year is distributed across the states. And it helps caregivers get with training, find resources, have some respite care. And around 750,000 caregivers have taken advantage of this program over time. Now I want to talk about the 2 substantial direct policies that support caregivers in the US. I'm calling this the state level, even though Medicaid is the national and the state program. This exists in 25 states in which you're able to pay your family member to provide care. Norma Coe talked about it yesterday in one of the demonstrations in her presentation where there was actual randomization. But in general, 25 states allow you to pay a caregiver. There are some limits on who you can pay. You can't pay your spouse or if the beneficiary, for example, a child is your legal dependent. But you can be paid between $10,000 and $20,000 annually as a caregiver. I couldn't get numbers on exactly how many, but my back of the envelope calculation, given that there are 1.2 million waiver users in 2007, is that maybe up to 200,000 people. But I think that's pretty inaccurate. I would love to hear whether anyone knows that number for sure. The other substantial direct policy is a very specific caregiver population and patient population, but it is available nationally, and that is through the Department of Veterans Affairs. So you may not be that familiar with the VHA healthcare system, but it's the largest integrated healthcare system in the country. And they have a mandate to serve veterans ever since the Civil War to provide healthcare for veterans. As I said, there are about 9 million people in this system. There are 150 medical centers nationally and 1,400 community-based outpatient clinics, nursing homes, and vet centers that offer mental health counseling, for example. There's also, since 2000, having care in the community for long-term care has been a standard benefit of people in the system. So it's very different from other not Medicare or Medicaid beneficiaries. Sorry, Medicare beneficiaries in particular. So in 2010, a new law passed that required the VA to expand its mandate and support caregivers. They've done this through 2 different mechanisms. They created a comprehensive caregiver program, and it's really specific to a post 9/11 era of caregivers. So if a veteran needs help for more than 6 months with ongoing management of personal care functions in everyday life, or if they need an enhanced ability to live at home safely, or if the caregiver supports the veteran's progress in rehabilitation, they get a clinical assessment and they can qualify for this program. The benefits can be very generous depending on the acuity of the patient. So once they go through sort of basic training in caregiving and also they assess the patient, they could receive between $7,000 and $28,000 annually. This program is rolled out for the last 3 years, and there are 17,000 caregivers receiving the comprehensive program payments and other services. 4,500 people have taken up health insurance. If you didn't have health insurance before, you can get it through your the VA, through the military health care insurance. You can also get other services. The other services are generally through this general caregiver program. This is not limited to any kind of era of service in the military. It's open to any caregiver who's in the VHA healthcare system, so anyone can take advantage. The statistics on who took advantage is very poor because there's no reason to register, but they ask people to register, and around 23,000 caregivers have registered in this general program. As a part of implementing their program nationally, they hired 225 social workers, nurses, or some psychologists nationally. So at least in all of those 150 medical centers, there's at least one social worker in each who helps with training, managing a support line, offering support groups, and giving other services like navigating the healthcare system for the caregivers. So this is sort of the most substantial program in the country, but of course it's only available to a select group of caregivers, those of veterans. So again, this is very back of the envelope, hence the disclaimer down here, very rough. But I took a denominator of around 20 million caregivers, so that's on the lower end of what we think are out there. And I took those 5 programs that are direct. And I thought about, okay, who is really being served based on those numbers, realizing that they're not that accurate. But really only 3% of caregivers are reached by direct programs of support. Let me move to the empirical evidence on the economic impacts of informal care. Okay, so this is a very busy slide, but it kind of shows what are the types of studies that are out there. And I want to point out there's variability a lot in whether we worry about this arrow here. So some people just look at associations, and I and other colleagues really obsess over how can we estimate the causal impact of informal care on key economic and health outcomes. So I think there's a mix of this in the literature, but it's something that I think primarily why you call it the economics of informal care is trying to use these econometrics or methods in order to really tease out this causal effect so we can understand what would happen if we made any changes. So there are many studies that look at outcomes. Informal care does seem to causally reduce spending on the Medicare recipient. There is some association between informal care and high out-of-pocket costs. There is a causal impact of informal care on worse short-term health, which I call this an economic outcome because worse short-term health means higher expenditures for the caregiver, potentially. There's a relationship between intensive caregiving and more psychotropic drugs, again, possibly to treat the ill health effects of being a caregiver. And then, by far, most of the research on economics of informal care is on caregiving and work, wages, and earnings. As I said, there are varied approaches concerning these, whether we worry about causality or not. And I'm going to focus on work, wages, and earnings since that's where the most of the literature is, and probably such a huge role in people's lives that it is important to focus on it as an economic outcome. This slide is borrowed from Megan Skyra, who I'll talk about more in a minute, but this is sort of a preview of the literature both in the US and internationally. Not every study is listed here, but it just highlights a few of them. Generally, the findings that really focus on the kind of short-term trade-offs between caregiving and work and look at trade-offs in isolation find the following. There's a negative correlation between caregiving and labor force participation. There's some mixed evidence on how caregiving affects work hours. Some studies find that they go down, others find that there's no effect. It can also very much depend on how you treat gender or different gender effects. There's general finding that caregivers do not return to work after a caregiving spell. caregivers incur current wage penalties, some very modest and some more significant, between, I would say, 3 and 13% or so. And then this just points out something that Megan really takes off on, and that is that most models really just look at the current and they don't consider future costs or future trade-offs that people make. And that's one of the key contributions that she makes in her paper that I'll highlight in a second. So a paper by Norma and Megan and I would say is not too shabby, even though Megan's is much better. It's always annoying when the student outlearns the teachers. That happened really quickly, so we just have to move on. So we worked on a paper with the Health and Retirement Survey that really did focus on controlling for these unobserved and observed sources of selection bias into caregiving. So I think we did a nice job in our 2013 paper of worrying about causality through instrumental variables and also using fixed effects to sort of control for unobserved characteristics that may lead to differences and bias in the results. But then comes Megan, and she takes a structural approach, which really is amazing in terms of being able to do some policy simulations and really look forward over time and see what the trade-offs are that people make. So she looks at how the informal care effects work and also how informal care affects welfare over time. And that's a key contribution to her paper. Her basic findings here are that caregiving affects current and future labor market outcomes through several channels. Caregivers she finds are less likely to be working, especially full-time workers. Women who leave work have a low probability of returning, up to 10% less likely to receive a full-time offer after caregiving, and about 6 to 14% less likely to receive a part-time offer. She finds that those who do return to work return to a lower wage. This is focusing, I should have said, on women and caring for their mothers. Caregiving, she finds, is persistent, especially if the parent's in poor health. And one of the beauties of her model is that she can look at changes in human capital and changes in parental health status over time. So just to point out sort of a synthesis of what really matters in terms of what explains some of the differences of effects both in the US and internationally is that we need to really worry about tasks. Tasks seem to matter. If you consider chores versus personal care, and it's important to tease those out. They have different effects on retirement versus work versus hours for men and for women. Intensity also matters very much. Most of the bang from informal caregiving and the negative work effects, not surprising to anyone in this room, comes from the intensive caregivers. Intensive adult daughters reduce their work. Intensive adult female caregivers are more likely to retire, and caregivers of veterans who have polytrauma are more likely to quit working. So now I want to mention sort of why we think the economic effects may be underestimated out there. And part of it is that we focus on what we can quantify using large national data sets. It's really hard to quantify some of the other losses that are equally important to consider. Again, in terms of labor force or work, there are changes in work productivity, lost promotions, temporary losses of pay, slower earnings growth, pension losses, or job lock that we need to consider. Job lock isn't really the traditional sense of I need to stay on my job to have health insurance, but if I'm caring for mom, I have no mobility to move and find another job elsewhere. There are also important spillover costs to family that are difficult to quantify, but important to consider. So job lock for myself, but also maybe for my husband. The other thing is it's really difficult to quantify some of the utility losses from the intangibles. Okay, so people talk a lot about the lack of choice in informal care, and a lot of times psychological outcomes are better after you become a caregiver if you feel like you had a choice. There's a lot of literature in this, in gerontology literature. And it's no surprise to anyone in this room, but family dysfunction doesn't just disappear when you become an informal caregiver. This is some of the quotes that I heard in a recent caregiving skills training trial research study that I'm conducting at the VA, in which caregivers were talking about the benefits, the rewards, and the frustrations of caregiving. And while they were all saying it's wonderful, they feel so good, they get to pay back their parent for caring for them, they also said, my dad told me that I don't care about him, I'm fat and need to go on a diet, and I can't keep a job or a woman. So I think we need to think about some of these intangible, maybe negative hits to our utility and well-being from becoming a caregiver. In terms of the difficulty of quantifying the welfare losses to caregivers, I want to point out, again, Megan's work. So going back to that $450 billion when we value informal care in the US at a replacement wage, Megan also does this. She's able to reproduce around this 21,000 value of what you would make a year if you were a caregiver. That's what Lynn Feinberg at AARP did very nicely. So if you think about that, then $21,000 is the replacement cost. And the beauty of what Megan did is that she looked at lifetime foregone labor income and finds that it's a much higher cost to the caregiver, $51,000. But then if you go and look at static and dynamic welfare costs, it's a whopping $165,000. That's the cost to the caregiver over 2 years for a 50-year-old, a woman in her 50s. That looks suspiciously like 2 years in a nursing home, and Megan points that out really well in her paper. So $164,000 is around the same cost of 2 years in a nursing home. It just also highlights the importance of looking forward and considering sort of the full welfare costs and not just the replacement wage, maybe grossly underestimating the cost to caregivers. This is just showing that it's 7 times higher if you consider the welfare costs. Why might the economic estimates be overestimates? So it's difficult to frame losses against economic gains because gains are also hard to measure, some of them. So some people talk about caregiving as a way to get new training and to enter the labor market, maybe even for skilled workers, but I don't know of any studies that have looked at this systematically. It may be that the caregiver who quits work or reduces work has a spouse with a higher wage who compensates for those earnings. Again, this is also very difficult to do. Notice there's no year on this paper because we can't get it to really behave. But thinking about how people compensate within families is also important to consider. There may be health gains, not just health losses. So we know there are rewards to caregiving. Of course there are. That's why people do it, choose to become caregivers. There's one study that shows that around 9 years later that there was an 18% chance of reduction in mortality from caregivers of stroke patients that came out this year. So I think we need to delve deeper and understand whether there are how the gains and the losses to health of the caregiver really balance out. There are other things like protecting your inheritance or saving on housing costs if you move in with each other that may kind of be economic gains to consider. Similar to having a hard time understanding how to measure the utility losses from the intangibles, the utility gains are also hard. So these fulfilling your reciprocity norms or paying your parent back, meeting cultural norms, having a demonstration effect where you show your kids that you cared for your mom, so maybe they'll care for you if you want them to. And then altruism, or it makes your mom happy and you gain utility from that as a caregiver. So now I want to move to what is an optimal policy to support informal care. Okay, this schematic is sort of something that I have used to think about how clinical trials or interventions would affect caregiving, but it really is relevant to caregiver support policies. So let's say we have a new policy. It could either directly affect caregiver activities, so clinical care, psychological coping that the caregiver can do, support seeking, ability to navigate a healthcare system, or the quantity of informal care. For example, let's think of a training program that is enacted for caregivers. So if it's something that affects caregiver activities, an optimal policy you hope will increase those skills. On the other hand, you may not affect caregiver activities, but if you have like a tax credit policy or something more substantial, payments to caregivers or paid leave or unpaid leave, it may directly affect outcomes and not worry about the activities. So you may improve the healthcare work wealth of the caregiver and hopefully also the healthcare satisfaction and quality of life of the recipient. What is not an optimal policy? So we don't know exactly what this would be, but I think one of the things that we worry about a lot is trying to minimize distortions that you would create from any policy. So what you don't want is a policy that creates a bunch of caregivers who are new, who quit their work in order to gain a benefit. So in this sense, the quantity of caregiving may go up from this policy, work is going to go down. And so what are the relative benefits of that? That seems like something we don't want to encourage. Similarly, we don't want a policy that increases total unmet need. So if the caregiver starts providing more care to the parent, they may let go of the formal care provider, or they may let go of the other caregiver who isn't getting that benefit. And if the net hours of care that the parent receives or the recipient receives goes down, that also is not an optimal policy, I would say, because it may affect the health negatively of the care recipient in reducing total care. So I think in order to kind of move forward, we need to think about how any policy would affect these green arrows and increase those and kind of reduce what I would call undesirable effects of a policy. And to do this in the context of what the net cost of that policy is, and in terms of that net cost of that policy compared to alternatives. So what do we need to move to next? What's the 2 questions in economics research that I think we need to answer? And then I'll talk more about the soul searching I think we need to do in the US. So since this is stolen from our wonderful conference guide, I'm going to focus on outcomes, and that's one of the areas that this conference covers. So the 2 economic research questions I think we need to do are to look at what are the long-term healthcare costs to the caregivers from the health effects of caregiving. So there are losses, there are also gains, and we need to really worry about how to causally measure these in order to understand both the health effects, whether it's just a temporary increase in stress, or whether people don't really recover from their experience as a caregiver. The second question, I think it's even more important, is I think we need to really understand what the relative value is of investing in informal care versus investing in formal care. This is probably obvious, again, to everyone in the room, but I think a lot of times we think we should support caregivers more, but there's a lot of problems with the way we support formal caregivers in the US, and what are the trade-offs with those? What do you gain in outcomes? One way to get at this as researchers is to understand the causal effect of how these 2 sources of care affect care recipient outcomes, and a broad range of those, so functional status, depression, mortality. How does it affect preventable hospitalizations, emergency room visits, and then quality of life and life satisfaction. So trying to get at whether there's differences in how these sources of care match people's preferences. This is the soul searching part. So I think there's a lot of research recently that challenges this notion that informal care is the preferred source of care in the US. There's a national survey that just came out that showed that 40% of older Americans prefer professional care and 31% prefer care from a family member. There's also research by Tamara and colleagues at University of Chicago who look at time trade-offs, and they found that people prefer care at home, of course, versus institutional care, unless you're severely impaired, and then it doesn't matter, or they may even prefer institutional care. So really, your preferences depend on your health state. I think that recent qualitative work that we've conducted too in our team has found that there's this desired role for kids to be provide support, but not to burden the kids, and the parents also don't want to be a burden to the kids. So this challenges this notion that we want to go to caregivers first and instead of formal care providers. Family context also really matters. So whether someone wants to rely on an informal caregiver really depends on the opportunity cost of your kids and what they're up to, and whether you're going to find alternative financing. We find that people who have high opportunity cost of their kids are more likely to buy long-term care insurance, so less likely to rely on future informal care. Then I think it's, again, a question of how do we value investing in informal and formal care? We need to talk about fairness. So what we ask of caregivers, frankly, is illegal for home health aides to provide in the home. A lot of times they're doing really high-level care, and we wouldn't let a home health aide provide that, but we let family members do it. So things like tube feeding and cleaning wounds, and I really think that this is an area that has little regulation, and there's a lot of debate about that. But why do we think that we're going to get higher quality of care for untrained people who don't have backgrounds in medical care? The notion of choice, I think, is very important. People who have choices feel better psychologically, have better outcomes. And then people talk about informal care as a women's issue. Of course, most care recipients are women, older women, and also daughters have traditionally been the care providers. But I think it's a working family issue as more women are working and as more women are the primary breadwinners in their families. So it's really an issue that we need to think about in terms of maybe along the lines of daycare. So women couldn't work and have a lot of work activity until they had good daycare. Women and men can't caregive and work without options for their parents if there is no other alternative in the future. I want to go back to Megan's study where she used her results to consider the effects of informal care on work and caregiving intensity because it shows some of the trade-offs that we make across different policy realms. She considers unpaid leave, paid leave, and a caregiver allowance. And this graph will orient you to it, but what she does is look at the baseline levels of intensity of caregiving and the percent who are working after an intensive care provision. And she finds that first, with the baseline case, that 14% or 15% of people were intensively caregiving, and 24% of those moved to full-time work after their episode. And then these policies have very different effects on both intensity of caregiving, but also on who's able to work after. So the unpaid leave leads to slightly more intensive caregiving, but it gains you about 5 percentage point more people are able to return to work after their intensive caregiving spell. Comparing that to the caregiver allowance, where you pay caregivers indefinitely, it's a very generous allowance that she constructs. If you pay caregivers indefinitely to provide care, you have much more intensity, but you have way lower labor force participation at the full-time level after that intensive spell. I just say that because I think it's important to think about these different policy arenas, and that labor market goals, for example, keeping women in the labor force longer, is not really consistent sometimes with having a cheap source of informal care in the home. The other thing to point out is that in our soul searching, I think we need to figure out what we most value supporting. So what types of caregivers, if we are ever to move forward with the informal care support policy, would we focus on? Would we think about the intensive caregivers, those who have probably the least, the most negative economic impacts after the caregiving spell or during their caregiving? Do we focus on workers? Do we focus on those who are economically the most vulnerable? Caregivers who are most at risk of bad outcomes? Or patients at most risk of nursing home care? People in the home health care expansion era, so Josh Wiener knows well about this, that it's really hard to target those people who are most at risk of nursing home care in order to really, if we wanted to target services to those who are going to be the most costly patients in the future, or most at risk of bad outcomes. So back to the final question, do we know enough to recommend an optimal policy? And I know this is very flip to say this, but I will give a couple of tentative examples. I think it's such a complicated issue, and I've enjoyed thinking about it, but I will offer kind of 2 tentative potential solutions, although I really do think that, in my mind, it's not clear whether we should be focusing on any money towards caregivers versus really bolstering the formal care support system in the U.S., which is very limited for most Americans. So we could take Megan Skyer's results and consider adopting an unpaid leave. And the reason that I say that is that really reducing the uncertainty of being able to return to work had a huge impact on increasing welfare of working women. So just getting rid of that uncertainty is a huge step towards enabling people to work again. Another thing we could consider is pension credits. So the UK has done this on a modest level, and other Scandinavian countries and Australia. I think Australia was at least proposing it. Someone could correct me from Australia here. And that is, we could design something that has Social Security contributions for caregivers when work is prohibited or when a clinical need is assessed and validated. So of course you would need oversight to me to be able to really regulate this policy. But if you focus on future payments to the Social Security system, it may help minimize distortions from such a policy, because you're not going to be having people immediately leave work to gain this wonderful benefit. You would be more protecting their preventing poverty in their old age, because so many low-income Americans really do rely exclusively on Social Security. This does make, of course, a targeting decision in recommending pension credits through Social Security. But again, that means that you're really trying to appeal to the economically most disadvantaged Americans. So I think for next steps, in order for us to move forward with any kind of policy in the US, these are the things I think we need to consider. We need to consider the net cost to government of caregiving as it is, so sort of in its static state, and also what would happen with any kind of policy change. We need to do a better job of thinking about the full economic losses and gains. We only focus on what we can quantify because that's all we have. And to think about the value of informal care versus formal care in terms of quality of care, outcomes of the caregiver and the care recipient, preferences, whether these sources of care best meet people's preferences, and in terms of fairness. I think we have to think about potential distortions and then trade-offs across multiple policy realms, so labor policy goals and long-term care policy goals. And then think and decide explicitly who we want to best target with our policies if we move forward. Thank you.
The costs of unpaid care for people with dementia. And one of the questions we have is, when we look at older retired carers, how do we value their time? They're really giving up leisure rather than work time. And I was wondering if you had any thoughts, recommendations on that.
Yeah, so most of the work does really focus on sort of the replacement wage, which isn't relevant for people who've retired, right? And it sort of undervalues that loss of their time. So I don't know of any studies that really focus on kind of valuing the human capital that retired people have gained and also their losses to leisure. But I think it's a really important factor. You thought your life was going to go a certain way. You worked all your life and worked really hard, and then all of a sudden health state has changed and you're now not able to do all the things you were hoping to do in your retirement. So, but I'd be eager to hear if there's other literature from PSSU or others.
In Europe, we have this thing called the open method of coordination, which is supposed to be a way in which member countries of the European Union can learn about beneficial policies. And this open method of coordination covers social policies, including long-term care policies, so that there is supposed to be an exchange of information about possibly good practices, possibly best practices, what works and whether it is transferable between one European member state and another, and bear in mind that they are very heterogeneous. Is this something which you've looked at? Because when you actually start searching for the way forward and what we can do and are the outcomes, it seems to me that there is something that one can possibly learn from this process, although I think there are also severe limitations to this process, particularly in the question of what is really transferable, what is the context in which something works, when and how. So there are an awful lot of determinants of what really makes success, and policymakers love to proclaim their successes without taking account of how these came about.
Right, so I don't know of that website, but I've certainly, reviewed everything that's going on in Europe and cases in Germany and Netherlands and the UK. There's so many different institutional differences and the social safety net. I think it is somewhat hard to learn, sort of, given that there's a really robust formal care market, then what do you do to caregivers versus us not having very much in the formal care market, and considering what would happen if you support caregivers. But I've definitely reviewed things, and I'll look at that website.
Hello, Marianne Bloch from France. I have a question regarding the heterogeneity of the population of US and how you consider policies that would be adapted to all these different populations. So because here it's more a mean policy you have been presenting, but I guess it would be very different in New Mexico, in New York City, etc., in Minnesota. So how do you foresee the adaptation of these policies?
Yes, it's very heterogeneous. Both, every state is very different. I think, on the state level, people are taking the money from the National Family Caregiver Support Program, and they're tailoring it to what their state needs. For example, in New Mexico, they may spend more money on respite care, and in New York, they may spend more money on training, for example. But I think I think it's why things that are happening on the state level, because it meets the needs of their population. So there may be kids move away from New Mexico, whereas they're nearby in more metropolitan areas. So I think that's one of the barriers in trying to understand how we meet the needs of everyone. If you pass one policy, it's not going to. But that's why I think we need to decide on targeting. So how would we just target the most intensive caregivers, the working caregivers, or think about focusing on the caregivers most at risk of bad outcomes, or the patients, or the poorest ones?
Okay, last question, I think.
Josh Wiener, RTI International, Washington, D.C. So, Courtney, I wanted to ask you about paid family caregivers under the Medicaid program.
Mm-hmm.
So, one of the things that I've sort of struggled with is that there's a lot of effort to try to improve and increase training requirements for personal care workers, but there's very strong resistance to doing that for paid family caregivers. But that strikes me, I understand that resistance, but it also strikes me as very inequitable, and I guess I think there is something to be learned in terms of the training, but a lot of the family caregivers don't want to go through that training. Do you have thoughts about that?
Well, I can tell you a little bit how the VA has handled this since it's such a new program, and my group is tasked with evaluating it. So we've learned quite a bit about how they require training before you get approved for the program. So you have to get certain training, both online training and well as people coming into your home to assess the situation of the particular patient. But it's very expensive to do this kind of training. But that is an option, that you require it and that you make stipends or approval into, for example, the Medicaid waiver program. If you're going to pay family members, that you require them to take certain training. But I know that I can understand the resistance, but I also am not that sympathetic to it, because you are asking people to provide pretty intensive personal care, and I think there are a lot of quality concerns. There are quality concerns for formal care home health care providers, so why wouldn't there be quality concerns for even lower trained individuals who have a personal relationship with someone?
Okay, thank you very much, everyone, and thanks again, Courtney, for an excellent presentation.